going to tell you a bit about the Pears Maudsley Center and how we hope to use it to transform children and young people's mental health. It's great to be coming now after you've heard Grania speaking, David Bradley telling everyone here that child and adolescent mental health is the area that he's most concerned about. You can see that that fills me with anticipation and dread, as well as knowing that, of course, we're in his sights and we have his huge support, as well as support from KCL and KHP, so to such a great extent. But let me just perhaps start by highlighting some of the challenges that have already been discussed in more general terms to you. And what you'll see on the graph on the left-hand side are the British household surveys of children and young people's rates of child and adolescent mental disorders from 1999 to 2022. And the reason I've used these data are they are using the same metrics. And an issue in mental health is always, are you comparing apples and oranges? And as James highlighted, we want to make sure we're comparing apples and apples. So in 1999, we had an estimate of just under 10% of children and young people having a mental health disorder. And that fitted very much with the wisdom of the day. We were all quite, we thought, yes, that's what we expect as a number. And what you'll see if I pulled down there is we also knew when we had that just under 10%, that those children and young people who had a physical disorder were twice as likely to have a mental disorder. And those with what I call a brain-based physical disorder, something like cerebral palsy or epilepsy, were 5 times as likely to have a mental disorder. So highlighting the real need for the physical-mental interface that we've heard so much about in the last session. Now, I think the graph speaks for itself. In recent years, we've added into those censuses polling or surveying children or adolescents are 17 to 19 years of age. And what you'll see is in 2017, again, they started at the roughly 16%. So there was an increase between 10 and 16% to 2017. And then you'll see, particularly for the oldest groups, this whopping increase to 1 in 4 young people having a mental health condition. And the important issue that Grania highlighted earlier is that we know that 75% of adult mental disorders begin by the age of 18. So if this increase is correct, it's sort of highlighting the potential tsunami of mental health conditions that will affect not only children and young people, who are, of course, my area of interest, but what is to come for adult services. So a real issue and real concern. Now, why might we have these increased rates? I've highlighted some of the reasons, which are certainly not mutually exclusive on the right-hand side. First of all, there is clearly increased recognition of mental health conditions. So as a society, we're more literate about mental health. And there's also less stigma. Young people are remarkably open about their mental health and the issues that they're experiencing in a way that I think many people in this room would not have been, and online, would not have been when they were adolescents. We also possibly have a degree of what I'm calling diagnostic substitution, which is a relabeling of issues of mental distress, like loneliness, as a mental health problem, as depression. Now, some of that will be mitigated by using the same measurement, but I think if people's perception have changed, that may have an effect. And of course, we've also heard highlighted some of the changes in social factors and social stressors that may increase mental health problems. Now, we know that, of course, biological factors are really important in who does and doesn't develop a mental health problems, but we also know that we're not going to have mutation in genes over a 6-year period. So we really have to look to the interplay between biological factors and social factors when we come to understand why there's such an increase in child mental health problems. Now, I just want to focus quickly on the very bottom of this slide and get you to reflect on this. So NHS England has set as its expectation that 35% of children and young people with a mental disorder are seen by child and adolescent mental health services. We're not achieving that at the moment, but just reflect on that. Would you expect that 35% of people with infections were seen for their infection? 35% of people with cancer were seen for their cancer? Why it really, to me, highlights the disparity still at some levels between mental and physical health. And I know that's not the view in KHP, but it is the prevailing view still in the country. So what is our ambition at KHP and with the Pears Maudsley Center? It is very high aiming that every young person should be able to enter adult life with robust mental health. Big challenge, but we want to provide prevention and intervention at a population level. And the Pears Maudsley Center and the King's Maudsley Partnership, that is the infrastructure of this center, is the way in which we hope to achieve this transformation. There's an image of the Pears Maudsley Center, which is almost completed. And apologies to those listening on the Denmark Hill campus whose work life has been ruined for the past 2.5 years by the sound of loud builders at all times of day. So my apologies, and I hope that you'll all find that it's really having benefits for you as well as for us. This is an £80 million build, and it is a co-production of funders from SLAM, the King's College London, the Maudsley Charity, other philanthropists, and Research England. And we're really very excited by what the building's going to provide for us when it opens in 2024. So briefly, how do we aim to transform children and young people's mental health? This is a sort of different view of the translational pipeline that you'll be well familiar with. But obviously, the first thing that we need to do is sort of harness new methods and new science to have a better understanding of the biopsychosocial interplay and how it leads to mental health conditions and mental health traits. Who exposed to social risk factors develops a mental health problem, and why. And within the clinical research facility in the Pears Maudsley Center, we have a bespoke children's and young people's set of cutting-edge methodologies focused predominantly on understanding what's happening in the brain. And we'll be able to stratify according to children and young people exposed to certain risk factors, those with underpinning disorders, or and presenting with different phenotypic presentations. Critical as well to our clinical research facility is the way in which we'll use digital infrastructure right throughout the building. So the ground and first floor have our research and clinical rooms, which are dual purpose for both research and clinical work, to allow us to collect a host of digital data that will be critical in informing, for example, speech patterns, visual patterns of facial recognition and emotional expression, and critically will allow children who have compromised communication or challenged behavior to be captured in their routine clinical contacts. when we make new discoveries, as we make new discoveries about why one child develops a mental health problem, why one child responds to conventional intervention and another does not, we'll be able to develop novel interventions, trial them within the center, again, looking at what happens at a brain, physiological, cognitive level, so on and so forth, so we better predict who responds and do that in a more timely way. And of course, the final element for us in terms of this translational pipeline is to be a center that implements effective new interventions and then disseminates them at a national and international level. So implementing locally first, seeing what works and what doesn't work, and then disseminating. So how do we achieve this acceleration and change? Well, critically, we do this through our partnership in the building. And so clinicians and researchers are going to be co-located next to each other. And that will really change what we do so that we will change from, oh, we have a bit of interesting kit here, what could we do with it, to clinicians telling researchers, well, this is the most pressing question for me. How do I treat anxiety in very rigid children who won't even come into the center? So that dialogue of how do we harness the research to ask the pressing clinical questions? How do we ensure that our researchers are clinically literate and our clinicians are research literate? How do we develop a shared set of priorities that we achieve within the building? And of course, one of the things that we really hope to do is achieve collaborations not only within the IOPPN and Maudsley, but right across King's. Social science, neuroscience, AI are all part of how we will achieve this ambition. And also collaborations outside of King's. So we hope that the clinical research facilities will be a beacon for collaboration with, for example, pharma, digital companies, and AI more widely. Now, what are some of the challenges for us? Because this has been a huge ambition. We've been fundraising and building since 2018, and we're really at the cusp. And I say to my colleagues, sometimes the darkest hour is just before dawn, because we are experiencing, it is a time when we really want to make sure that the huge work that everyone's put in really has the impact that David and I are both hoping it will. And the first challenge, we've heard a bit of this already, is around people. Our clinicians are working incredibly hard. We have up to 2-year waiting lists in some of our services, and asking people to do something extra, even to do something different, is really challenging. So generating that motivation is really, really important. Being able to build and that goes for researchers as well, who are working really hard because we know research funding is tight, and we often have to achieve very ambitious targets with our science. There are real challenges around processes, so we're trying to incorporate NHS and KCL processes into the same building. Those go from information governance to make sure that our patients' confidentiality are paramount at all time, but the building can be used in a flexible way by researchers from a range of different backgrounds, and we can allow collaboration to happen quickly and readily. And as I've alluded to, finally, it's around achieving the ambitions and the hopes that I and everyone else has of us. We know that science itself, from discovery science to a seismic change in how we deliver healthcare, takes time, and We won't deliver that overnight, as we've just heard. There are ways in which we can make real and meaningful changes. So one of the questions in the last session, for example, was how do we motivate clinicians who are inputting data to see the rewards of that? Well, we've actually decided that the best way to do that is to try to bypass the clinician in terms of inputting data. And the My Health system that Grania referred to means that we get patient-reported data directly from patients and their families, and that's inputted into the clinical record. And the change so the clinicians can see that, and the change that we've just implemented this week means that the clinicians can see not only graphs of what's changing with patient symptoms, but they get graphs that indicate whether the symptoms are below a clinical threshold and whether meaningful clinical change has been achieved in care. So this not only helps our clinicians, but it will help our stratified medicine approach. So although there are huge challenges, what I'm really hoping is that with our amazing center and the importance of working collaboratively, and by putting young people who have co-produced and have told us how they want this center developed, we will be able, in 10 years, even 5 years, to come back and tell you how we've transformed children and young people's mental health. Thank you.